traditionally we think about, or historically we think about rotator cuff injuries in the summer months with the throwing athletes, the baseball players, softball players, tennis players. But actually, as we now know, winter is coming. And that does not mean that the rotator cuff tears go away, or the other shoulder injuries go away. There are many activities in which we all participate during the winter months that can cause just as much heartache about the shoulder as pitching and playing tennis for long periods of time. This probably isn't one of them, but if we think about the other ones that we'll go through, I'm hoping that I can maybe clear up some of the confusion about, quote, rotator cuff injuries that I see every day in my practice. And I think that the easiest way to do that is to impart some information to you all that will hopefully be helpful. And I think when I teach residents and medical students, we always start with the basics and we start with anatomy. I also think it's important to remember that the primary purpose of the shoulder is to put your hand where it's supposed to be. It's not to beat on things or run and dip people this way. It's to put your hand where it needs to be so you can survive. If we then look at the different parts of the anatomy, we start with the skeleton and the bony anatomy. The bony anatomy, we look at this part right here. It's the yellow part is bone, and this, quote, ball of the ball and socket joint is the humeral head. This yellow part over here is the socket or the glenoid of the scapula. Up above, you have the end of the collarbone or the clavicle, and adjacent to that is the acromion. So this is the acromioclavicular joint, or the AC joint. When somebody says they've separated their shoulder, that's the joint that they're talking about. But the soft tissues about the shoulder are also very important. Sandwiched in between the bone of the ball and the bones up above are a lot of soft tissues. And if we go from inferior to superior, this is the joint cartilage, and then we have the joint lining or the capsule. And right adjacent to that, or on top of that, we have the tendons. Remember that muscles attach to bones through tendons. And then once we go through the tendon, there's a dimension, there's a thickness to those tendons. There's a surface that we call the joint surface or the articular surface. And then there's the top surface up here. And adjacent to that is this blue structure that's collapsed, which is the bursa. And that's a potential space. And the function of the bursa is to cushion these soft tissues from the bone that's on top of that. And then on the side here, we have the big deltoid muscle coming right down here. And you can imagine that if this muscle, if it's attached here and it's attached down here, and it contracts, it wants to drive that bone, the ball, right up into the bone up in there. And the rotator cuff muscles function to keep that from happening. And we'll talk more about that as we go along. But also, what we're going to talk about in a little bit is if we have a device in here with which we can look into the shoulder joint, you can imagine that if I put my arthroscope in this bursa or the sac here, because of these tendons and because of the ligaments, I shouldn't be able to see that ball. And that's important as we go through and talk about injuries. Hey. We just missed a little bit of an anatomy lesson, but we're going to keep going on anatomy. If we then look at it from another perspective, a patient lying down in an MRI machine, so the back is down here, and the front is up here, and now we see the ball up here, and we see the socket. And it's analogous to a golf ball sitting on a tee. The ball is much bigger than the socket, so it's inherently unstable. But what that allows is, because there's such a misfit or an incongruency here, that allows you to be able to move your arm a lot more than you can move your hips. Hips are built for stability, to get you around. Shoulders are, again, designed to put your hand where you want it to be. And because the bony anatomy is so different here, you can imagine this just blowing off. Where in your body, you're dependent on the soft tissues to stabilize that joint. We're dependent on the ligaments, which are called the static stabilizers. They're just there. They're functioning whether we call upon them to do anything or not. And then there are the dynamic stabilizers, which are the muscles around there. And that's what we're going to focus on tonight. The only way you can really see all four rotator cuff muscles is if you look at it this way, because the biggest muscle of all is the subscapularis, and it's in the front of the shoulder. Notice that all of these muscles in the rotator, these are showing all the rotator cuff muscles, and again, we'll talk more about them in a second. They all start on the scapula, or your wing back here, and then they come out and go under these bones, again, the end of the collarbone, and then the acromion. They pass under those bones and then insert on the top of the ball here. So the subscapularis is the biggest one, and that inserts in the front of the shoulder, the ball and socket joint. The other three, the supraspinatus, infraspinatus, and teres minor, insert on top and toward the back of the ball. Again, muscles attach to bones through tendons. If we then look just from the back, we can no longer see the subscapularis, but we can see the other three muscles of the rotator cuff more clearly. The supraspinatus is up here, then the infraspinatus, and then the teres minor. All of these three insert in the same place on the top and the outside of the ball. And again, their function is to hold the ball centered in the socket to keep the deltoid from pulling it up, and also to help you start your arm out to the side, to give you a lever advantage so the deltoid can then, with great strength, pull your arm up overhead. The other reason I put this in is to show all the other structures that are around the shoulder, the nerves and the arteries, because not all pain in the shoulder or injuries to the shoulder are rotator cuff. There are a lot of other things that can hurt the shoulder, but it seems like most people who come to my office say, I'm sure I have a rotator cuff problem. They're frequently right, but not always. If we then look at a spectrum of injury, starting on the minor end of injuries to the rotator cuff, it's actually not really an injury. It's inflammation of the rotator cuff tendons, in which case it's tendonitis, and inflammation of the bursa, in which case it's bursitis. But remember from the slide we looked at before, they're intimately related. The tendons are coming right in here, and the bursa is lying on there. And if it's not inflamed, it's a potential space. It's like a collapse balloon. But when it's inflamed, you can get fluid in it, and it becomes much more irritated. So an injury is not necessary to cause bursitis and tendonitis. It can just sort of happen in routine daily living. And these are folks who have pain reaching up overhead, because as the arm comes out to the side, it pinches that bursa in those tendons between the bones, and that hurts. The other thing that hurts people is lying directly on it, because if you're lying on your shoulder, it's sort of the, quote, point of the shoulder, you're pushing in there also. So usually early on, no history of injury, but people have pain reaching up overhead, lying directly on it. And a lot of times, I think what happens is, when I see folks who have really lost motion and are heading for a frozen shoulder, the first time they reach up to here and it hurts, the next time they're not going to go quite so far, and the next time they're not going to go quite so far, and it ratchets the motion down, and they really end up losing a lot of motion that way. So the least damaging part of rotator cuff pathology on the minor end of the spectrum is inflammation. Tendonitis and bursitis, no injury, frequently motion will be compromised. Usually strength is okay, it's only inhibited by the discomfort. But again, it's the most benign form of things. If we then talk about tears, not inflammation now, but tears, in terms of the mechanisms of injury, acute, people can usually tell you exactly the day, the minute, and what they were doing when they tore the rotator cuff. It may be a snow coaster, landing directly on it. It may be crashing into the boards playing hockey. It may be crashing into something else. But it's usually landing directly on it, the way the rotator cuff tendons fail. And again, one thing I didn't mention in the anatomy diagrams, the rotator cuff usually tears at the tendons, not within the muscle. And the tendons usually pull out of the bone, where the tendons hook into the bone. That's where the tears most commonly occur. So falling directly on the shoulder, the rotator cuff tendons fail in compression. Or if you plant a ski pole and you ski by it, you may dislocate your shoulder, but your rotator cuff can also fail in tension then. So it can fail in either compression or in tension, an acute injury, 1 day, 1 minute, that hurts. Or you can have many small insults or cumulative trauma in a more chronic setting. I can't really pinpoint the time, but frequently I'll see it in seasonal changes when people go from, say, playing soccer or something in the fall, and then they start playing squash in the winter, or they start cross-country skiing and then go to another sport. But it's sort of as they're ramping up into it, they'll become uncomfortable, get a little fraying of the rotator cuff, not really defined time, but just over a gradual period of time. And then you can also have an acute on chronic, where somebody says, my shoulders bugged me for 2 years, but I also fell, and then it got much worse. Suddenly I couldn't lift my arm up. And that's probably an acute on chronic, and I see it in the operating room all the time. And that can be difficult to address in terms of treating it. And I put this picture in the operating room up just for a reference to a perspective, because we're going to look at some arthroscopic photographs. So for orientation, this is the person's shoulder, their arm, their forearm and hand are in an arm holder. You can see the arm of the arm holder. It's a pneumatic arm holder, so I can put the arm in any position I want to do whatever that needs to do, whatever it is I need to do. The head is back behind these drapes, obviously the back. The person is sitting in what we call a beach chair position. And so when I'm doing arthroscopy, I'm usually standing facing the shoulder. So I'm looking in at the ball and socket, and the back of the shoulder, in this case, the back of the shoulder is to the right, and the front of the shoulder is to the left. And I put the arthroscope in there. Because now we're talking about tears of the rotator cuff as opposed to just inflammation. So the most common tears that are partial thickness tears, in other words, remember I mentioned there was a dimension to the tendons. There's a thickness to them. There's a joint surface of the tendons, and then there's a bursal surface of the tendons. The most common partial thickness rotator cuff tears are on the joint side or the articular side. They're much more common. You can see all this frayed tissue. This should be sort of a really nice linear tendon here. What I'm doing is debriding the frayed part of it there, but there's still some fibers that are intact. The more symptomatic partial thickness tears are on the top side, adjacent to the bursa. So what I'm doing here with the probe is, again, I'm standing looking at the shoulder this way. So the back is back here, the front's here, and I'm looking from the side right straight in. And I can see this part where I have a probe in there lifting up that side of the cuff, of the tendon, but there's still some fibers that are intact. I'm not looking at the ball through a hole there, as we'll see in just a minute. Bursal side tears are much more symptomatic than articular side tears. And if you remember one of the first anatomy slides I showed, the tendons of the bursa are sandwiched between bone, the ball of the ball and socket joint, and the acromion, the bone up on top. So when they bring their arm out to the side, this is like a ridge, and it gets caught under that bone. So folks will have what's called a painful arc, where they'll get up to a certain point where that tear contacts where the bone is sticking down, like a spike sticking down. And as they hit that, they get a lot more pain. So those are more symptomatic but less common. Partial thickness tears. If we then look at full thickness tears, again, I'm standing there, so I shouldn't be able to see, if I have my arthroscope in the bursa, these tendons, these are the stumps of the tendons. When they tear, they recoil like a rubber band. So they retract, and they can retract all the way to the level of the socket, quite a distance. So I shouldn't be able to see the ball right here. And the socket is right down here, and here's the stump of the tendons right up there. So that's a full thickness rotator cuff tear. Now these people, the partial thickness tears people may do fairly well with non-operative treatment. They will frequently complain of pain. They may have a loss in range of motion, and they may have a loss in strength if the fibers that are still intact are not strong enough to compensate for those fibers that are not intact. So they may still be doing okay, but uncomfortable. The most common complaint in my practice is pain. So although I'm a surgeon and I love to operate, we always start with the least invasive treatment and go to the most invasive treatment as we need to. Physical therapy is basically the cornerstone for treating rotator cuff pathology that is on the more minor end of the spectrum in terms of the tendinitis and the bursitis and even partial thickness rotator cuff tears. people can do very well with the bursitis tendinitis, including the modalities, which is ultrasound, phonophoresis, and iontophoresis. And they may be effective enough in partial thickness tears to keep somebody from benefiting by art, so that somebody can avoid having surgery. If the non-steroidal anti-inflammatory medications and also the modalities calm the inflammation down enough, which is what this is all designed to do, is to decrease the inflammation, to allow people to participate more wholly in physical therapy, to optimize the function of the fibers that are still intact, to compensate for the fibers that are torn. However, that will not fix a full thickness rotator cuff tear. And on the scale of least invasive to most invasive treatment, the next more invasive treatment are injections. Now, the non-steroidal anti-inflammatories, Aleve, Advil, ibuprofen, are designed to decrease inflammation. It's the inflammation that gives you discomfort. So you're taking that systemically. If somebody has tendinitis, bursitis, or even a partial thickness tear, sometimes I'll offer a steroid injection to put the most potent anti-inflammatory right where it needs to be. And the logic there is that it will, again, make you comfortable enough to fully participate in therapy to strengthen or optimize the fibers that are intact. However, there's also a downside to steroid injections. They can weaken the tissue. So I sort of cringe when I see people who say, yeah, I've had 5 injections and I'm not better. I go, because you can actually weaken the tissue, and if you have a partial thickness tear, you can propagate a larger tear. Or if you have a full thickness tear and you're getting injections, you can definitely propagate a larger tear. If a patient comes in and says, I know I have a rotator cuff tear, but I am never going to have surgery, which a lot of people do, and they say, but I'm really uncomfortable, then I will give them an injection with a full thickness tear, as long as they're saying they're not going to think about having surgery down the road. And then if we get to the ultimate treatment, especially of full thickness tears, there are 3 things that I consider when I'm talking to my patients about whether or not to proceed. Pain. And chances are they wouldn't be sitting in my office if they didn't have pain. A loss of range of motion. One of the hallmarks between having bursitis or tendinitis or inflammation is the fact that usually active range of motion will be preserved. One of the hallmarks of a full thickness rotator cuff tear is they lose active range of motion. Some people with a big tear will come in and they can't even lift their arm up overhead. But passively, you can bring their arm up for them, and then they can't hold it there. So that's a positive drop arm test. So range of motion, the loss, we consider they've had a significant loss in range of motion. And then the third thing is strength. If they've had a significant loss of strength, then we'll consider repairing them at that point as well. Again, it's totally patient-driven in my mind. In fact, I spend more time in my practice talking to people out of having surgery than giving them information about having it. So then how do we determine whether or not a tear is repairable? And I think it's very important for my patient and myself to be on the same page in terms of expectations. And it's helpful to go to the objective data after we've done our clinical examination and we have an MRI. X-rays show us bone and they show us relative positions of bones to each other, but they don't show us the soft tissues that we talked about being so important in terms of stabilizing and function and helping the shoulder to function. So this is an MRI in that same plane, the coronal plane that I showed the first anatomy slide. So again, here's the ball, here's the socket, here's the acromion up here. Now in an MRI, if you have blood or fluid, there's what's called increased resonance, and on these cuts, it'll show white. So what this shows is that this structure right here is the muscle of the supraspinatus, the top rotator cuff muscle that's most commonly torn, coming out to the tendon, and this tendon is supposed to be attached down here. So the white area of increased resonance here is fluid from a full thickness rotator cuff tear. So we consider, with an MRI on the different cuts, we can determine how big the tear is, how many tears are involved, and we grade those. The more tears involved, the harder it is to repair, and the prognosis is actually worse. Then we talk about retraction. When a tendon lets go, it's like a rubber band and it recoils. And it may go all the way back over here, like the one I just showed you a few minutes ago. So they let go. So tear size, tear retraction, and atrophy. If a muscle's not attached at both ends, you can't keep it strong. And once you have atrophy after the first 3 months or 12 weeks post-injury, that atrophy is not retrievable, it's not reversible. So the reason to do something surgically then is to prevent further atrophy and to help alleviate pain. So those are the considerations in terms of talking with somebody and saying, I think there's a pretty good chance that I'm going to be able to fix your rotator cuff. And then if we talk about surgical technique, 95% of the rotator cuff repairs I do now are arthroscopic and in the outpatient setting. I hardly ever open with a big incision the rotator cuff navigation. So again, the same perspective. We're standing looking in towards the ball and socket joint. Here's the ball, the humeral head. Here's the stump of the tendon. So it gets stuck to the bone above, the acromion, and it also gets stuck to the socket down below. The first thing I have to do is free it up, both on the top side of the bursal side and on the underside. And then once I do, this is actually sort of like a spatula almost that I use to go around. This is the socket. So I'm freeing up the undersurface of the tendon after I've freed up the top surface of the tendon. The whole time I'm doing that, I'm sort of pulling on it gently, seeing whether or not it's going to come all the way back out, because these tendons need to be out here when I finish, and that's at least 3 centimeters, maybe 4 centimeters. So once I've freed it all up, then I start to sew it back together. And I tell my patients, sort of like building a ship in a bottle. You have long instruments through cannulas, and you're looking at a monitor. So we pass sutures, we sew things together. So this is sewn together side by side here, but I still haven't anchored it back to where it's supposed to be on the lateral edge of the ball there. And the bone is hard. I can't sew into the bone. So what I do is I put in a row of what are called anchors. This is actually just a punch. We don't want to drill because we don't want bone to come out. We want to compress the bone to screw in a plastic headless screw that sits countersunk below the surface of the bone, and it has these stitches attached to it. This is just the metal introducer here, then I take that out, and then I'm just left with the stitches there. And I have different instruments with which to pass those sutures through that end of the tendon, and then when I tie it, it ties the tendon down where it's supposed to be, and we recover the head. So that's how we do it. And then the work begins. I do my part again as an outpatient, but then people are in a sling for anywhere from 4 to 6 weeks, depending on the size of the tear and the quality of the tissue. The larger the tear, or the poorer the tissue, the longer I mobilize them. So it's anywhere from 4 to 6 weeks, but when you come back in 2 weeks, you come out of the sling, bathe and do the exercises, but then go back into the sling otherwise. The most important part after surgery, once we've held you immobilized for a period of time, is regaining range of motion. You have a golden period, the first 3 months in which to get your motion back, but you have the rest of your life to strengthen it. So we really focus on range of motion initially. Once you've healed, then we want you to minimize the chance of it tearing again. So we ask you to avoid repetitive overhead resistance activities. Those are the worst things. And then when we think about expectations after you have your rotator cuff repaired, or if you have non-operative treatment with physical therapy, our goals are the same. And whether it's done arthroscopically or as an open procedure, our goals are the same. To provide comfort, have you regain your range of motion and your strength, and most importantly, to be able to return to your sports. Thanks.